Hello, everybody. Welcome to Totally TCM, Coding for Transitional Care Management. And I want to introduce to you Shay Lunch. She's our presenter for today's presentation. And Shay's got a great background. She's got a BS in Health Information Management. She's went ahead and got her master's in Health Services Administration. In addition, she's an RHIA, she's a CPC, she's a CPMA, she's a PMP. I could just keep giving you a bunch of abbreviations, but she's got lots of knowledge, lots of education, and she loves to train, and she does a fabulous job. Her experience is on the professional fee side of coding. She's done lots of auditing, education, and compliance. She's also served as project leads for some computer-assisted coding projects as well. So we're just really excited to have you here today, Shay, and we are excited to hear everything we can about what is transitional care management and how are we going to code it. So Shay, I think at this time I'm going to turn it over to you.
Great. Thank you, Kathy. I am happy to be here, and thanks for the lovely introduction. So today we're going to talk about transitional care management. What we're going to do is really define what transitional care management is and try to understand all of the CPT coding guidelines and the requirements that have been set forth by CMS for this service. So as you may know, this is a relatively new service when we look at our CPT services, and it's really important to take the time to understand what the requirements for this service are, especially when we start billing new services. So we'll go in depth with those coding guidelines and all the requirements, and then we're going to look at the CPT codes and how they should be applied correctly. So why is transitional care so important? Well, patients that are going home from the hospital, they usually are on the road to recovery, but many of them are not going to be functioning at that 100% level. And sometimes they don't even know how to get to that 100% level. And then even worse, we see situations where primary care providers might be uninformed that the patient was ever even admitted to the hospital or how they could even help that patient after the discharge. So the lack of coordination there, that's really what the transitional care management is focused on. So it's between the acute care facilities and the primary care providers. So nearly 1 in 5 patients is readmitted to the hospital within 30 days of hospital discharge, and that leads to a huge cost in our healthcare system. So that's estimated to be about $24 billion with a B each year. So since we rolled out TCM codes, that happened in 2013, the incentivization really from CMS is to improve that readmission rate. So that's kind of the whole point of transitional care and why CMS implemented these codes and started paying for this additional service. So let's go ahead and go into more transitional care and what that means. So this is defined in the CPT book, but it's really the services that are provided to patients that are transitioning from an inpatient hospital setting, and that it could mean a variety of different things, and then to their patient's community setting. So the hospital setting could be an acute hospital, could be a rehab hospital, could be a long-term acute care hospital, could be a partial hospital, observation status in a hospital, or even a skilled nursing facility or nursing facility. The patient's going from that type of setting to their community setting. So that could be they're going home, they're going to a domicile, which is where they're living at. They could be going to a rest home, or they could be going to assisted living. The services can be provided to a new or an established patient. It does require medical decision making of a certain level, moderate or high, and we're going to talk about that more in depth later in this presentation. So the period of transitional care management is going to be starting on the date of discharge and continuing for the next 29 days. So it's a 30-day service period as defined by CPT. One thing to point out here is that you don't see emergency department listed. as a setting that's acceptable for the patient to be discharged from. So emergency department, if the patient has only been seen in the emergency department and then is going home, the transitional care management codes are not going to apply in that situation. So 2013 was when Medicare decided to cover transitional care management services, and they were then appeared on the Medicare physician fee schedule. So back then, CMS estimated that 2/3 of all hospital discharges would be eligible for this service, and they also estimated that there would be quite a bit of additional reimbursements generated from this service, so about 4% increase in payments to family practice, 3% for internal medicine and pediatrics, and then 2% for gerontologists, nurse practitioners, and PAs. So again, why are they willing to pay for this services? It's really to impact the quality of care and try to reduce those hospital readmissions. Now, here we have in 2017, you may have seen this, but on the OIG work plan is transitional care management. So what they're looking at on the OIG work plan is, are these services being paid correctly, which is another reason why we're here today, is just to make sure we're really meeting all the requirements for CMS in order to not get caught up in these types of audits where things might not have been billed as they should have been. So let's go more into the requirements. Here's the code description. So we have 99495 and 99496. And these are in your E&M section of your CPT book. And you'll see them labeled under chronic care care management services. And it's going to be transitional care management services. They look the same, the codes do, except for there's a couple key differences, so I will highlight those. They're both going to involve communication that can be direct contact, telephone, or electronic, and you'll see this as referred to as interactive communication or initial communication, and that has to be within 2 business days of discharge, and that's the same for each of the 2 codes. So 99495 and 99496 both have that requirement. And then once we get down to the medical decision making, the 99495 is going to be moderate complexity. The 99496 is going to be high complexity. And then the other difference is the face-to-face visit. So 99495 has to be within 14 calendar days. 99496 is going to be within 7 calendar days. So those are the differences between the 2 services. One question that I've seen asked quite a bit is, does the face-to-face visit have to be on the 14th day or on the 7th calendar day? And the answer is no. You'll notice that keyword within. It just has to be within those specified time frames, not exactly on that date. All right. So the TCM services, there's a few different things that have to be met in order to bill these services. They are comprised of the 1 face-to-face visit that has to be within the specified time frame. And then there's a combination of non-face-to-face services that may be performed, and those can be performed by either the billing provider or licensed clinical staff that are under his or her direction. And then the interactive contact, which there is the specified time frame for those. So this leads us right into pop quiz number 1. So Kathy?
Okay, we've got our first polling question. I'm going to launch it. Okay, what do you think? Transitional care management covers how many days of service? Is it 30, 60, or 90? Please let me know what you think. 30, 60, or 90? Okay, we've got responses coming in. Ooh, we're going to have some discussion, Shay, on this one. Okay, looks like we've got people Ooh, great, 100% have voted already. Okay, I'm closing. I'm sharing the responses. Shay, we've got 20% of people out there are saying it's within 30 days. How many days does it cover? 30. And we have 80% who says it's 60 days.
All right, thanks, Kathy. So the correct answer is 30 days. So remember back at the very beginning of the presentation, I said the TCM service commences on the day of discharge. It continues for the next 29 days. So 30 days total for the TCM service. So we're going to talk about this more as we keep going, and it will come into play when we talk about different things like what date of service to build the TCM service on. Okay, moving right along. So I mentioned that there might be non-face-to-face services in the transitional care management service. So these are things that the clinical staff may provide to the patient if deemed necessary by the billing provider. So these are done at the direction of the physician or other qualified healthcare professional. And it could include, all of these or just one or two. It just depends on the patient and the patient's needs. It's going to be different for every patient. Communication regarding aspects of care. So this could be with the patient, with family members, with a guardian or a caretaker, could be with a surrogate decision maker or any other professionals. Communication with home health agencies and other community services utilized by the patient. Patient and or family caretaker education to support self-management, independent living, or activities of daily living. So any kind of education that might help the patient be supported in those activities of daily living, as you can imagine, could be pretty important for keeping that patient out of the hospital. Assessment and support of treatment regimen adherence and medication management. So to me, this one stands out as really important. You can imagine if the patient is not adhering to their medication as prescribed when they discharge from the hospital, it could lead to another readmission. Identification of available community and health resources. So this is important, I think, as well, because as we know, not all communities are the same in what resources are available to the patient, and patients might not even know what's available to them and what they could use for help. And then the last one, facilitating access to care and services needed by the patient and or family. So that kind of goes hand in hand with some of the other ones we just talked about. So again, this is things that clinical staff could do as non-face-to-face services depending on what the patient needs. And then here we have some provider non-face-to-face services. So when we say provider, this is going to be the actual billing provider, so either the physician or the other qualified healthcare professional. And these may include obtaining and reviewing the discharge information, so this is going to be the discharge summary when that becomes available, or any continuity of care documents. Reviewing need for follow-up on pending diagnostic tests and treatment. So maybe the patient got discharged and needs a follow-up x-ray. This provider would be responsible for reviewing the need for that and then following up on the test results. Interaction with other providers who will assume or reassume care of the patient's system-specific problems. So this is more than likely going to be any kind of specialist that the patient is going to see. So they could be seeing maybe a neurologist for some neurology problems, maybe an endocrinologist to address their diabetes care. Any system-specific problems, if that provider needs to have interaction with the primary care provider to provide better quality of care for the patient, that would be included in this transitional care management. Education of the patient, family, guardian, and or caregiver. Establishment or reestablishment of referrals and arranging for needed community resources. So, sometimes this does take a order from the provider or something like that to get these established. So that would help in that transitional care management time period. And then assistance in scheduling any required follow-up with community providers and services. So just really ensuring the patient's getting all the care that they can need in that time frame. So the guidelines say that the provider must furnish non-face-to-face services to the beneficiary unless they determine that they are not medically indicated or needed. Clinical staff can perform under the direction of the physician or qualified healthcare professional some of those non-face-to-face services that we just discussed as well. So let's go right into the specified timeframes, and there's a few that all are tied to the Transitional Care Management Service. So like I mentioned, the required face-to-face visit, initial patient contact, and the medication reconciliation all have specified timeframes. So the first face-to-face visit is part of that transitional care management, and you're not going to be able to report that separately. So you would not be able to bill an E&M for that face-to-face visit. That's part of the transitional care management service. So the first one is interactive contact. That's required to be with the patient or caregiver and must be within 2 business days of discharge, so 2 business days. For the purposes of TCM, that Transitional Care Management Guidelines say that business days are Monday through Friday, except holidays, and that's without respect to normal practice hours or date of notification of discharge. So they also go on to say that 2 or more separate attempts can be made in a timely manner, and if they're unsuccessful, you're going to go ahead and document that and continue to try to contact the patient. If you happen to be able to complete that transitional care management with all the other requirements met, you can still bill the service there. And the initial contact does have to be made after the patient leaves the hospital, and the purpose is to make sure the patient has the support necessary from the time they leave the hospital until that face-to-face visit. That's going to be within either 7 or 14 days, calendar days of discharge. And it can be by phone, email, text, or direct face-to-face. And I'll just give you an example here. Patient is going to be discharged Monday at 4:30 in the afternoon. And the question is, does Monday count as that first business day and then Tuesday as the second business day? Or is Tuesday the first business day and then the provider has till the end of the day on Wednesday? So in that scenario, the provider does have till the end of the day on Wednesday, and Wednesday is going to be considered the second business day following the discharge. And then the last time frame that's specified is the medical reconciliation, and that is no longer than the date of the face-to-face visit. So it could be done before the face-to-face visit, but no later than the face-to-face visit. So this chart is actually in your CPT book. So if you are looking at the professional edition, it is on page 50 of the 2017 professional edition. But this just points out the differences between the 2 codes. So again, we have 99495 and 99496. And the differences are going to be the face-to-face visit timing and then the moderate or high complexity. And you have to meet both the face-to-face time and the high complexity, you'll notice here, to get to that 99496 level. So if you happen to meet the high complexity, but then have your face-to-face visit within 8 to 14 days, you're still going to be stuck with that 99495 code. So that's a good reference to use just to make sure you're picking that right code. So I've mentioned medical decision making a couple times, and this is really where we have to put on our E&M thinking cap. So medical decision making for the TCM service is defined by our E&M service guidelines. So we pulled out the tables using Novitas's E&M tool but you'll see that many MACs are similar in this, and they reflect the 95 and 97 CMS E&M guidelines. So TCM does not specify history and exam requirements, but it does, again, say that medical decision-making has to be moderate or high complexity, and this follows the E&M guidelines. This is likely going to be demonstrated in the face-to-face visit, but it does say that the medical decision-making is for that whole 30-day period. So there's 3 parts to medical decision-making. The first table is number of diagnoses or management options. So that's table A. Then we have amount and complexity of data, which is table B. And then we have the risk table, which is table C. And how that medical decision-making works is that 2 of those 3 tables have to either be met or exceeded to pick your final type of decision-making overall. So let's just run through an example to demonstrate that. We'll say that we end up with 3 points in that first table for number of diagnoses or management options. Maybe we end up with 1 point for data down here for table B, and then our highest risk is either going to be moderate or high. We're going to be at least at this moderate level here because that's where we have 2 out of the 3 tables either meet or exceeding that moderate level type of decision making. So 2 out of the 3 elements there must meet or exceed. So let's go ahead and look at that first table. Let me erase, there we go. And you can see kind of how those points get added up. We have different types of problem status listed. So we have self-limited or minor problems that are 1 point each. We have established problems. Those could be stable or worsening, so 1 or 2 points. We have new problems with additional or with no additional workup. And these problems are going to be to the examiner. So this patient is coming in for transitional care management. They could be a new or established patient, like I mentioned. So these could be problems that they were admitted for that this provider has addressed in the past, or they could be problems that have never been addressed by this provider before. So that would determine whether these are new problems or established problems, and then documentation is going to need to reflect the rest in picking whether this is a stable, worsening, or a new problem with additional workup or no additional workup. And additional workup is just going to be anything diagnostic that's still outstanding that this provider is going to follow up on. So the total points get added up here, and that gets brought over to that first line we looked at for Table A on the medical decision making. And then Table B is going to be our data table. So there's no multiplying in this table, but you can get points if you have something in any of these categories. So lab tests, radiology tests, or medicine tests are 1 point. We have discussion of test results with the performing physician, which is 1 point. Decision to obtain old records or history from someone other than the patient is 1 point. And then we have the summarization of old records or history, which is a 2 point, or independent visualization of image tracing or specimen is 2 points as well. So those points get added up, and like I said, there's no multiplication here. So if they order 10 lab tests, they get 1 point. If they order 1 lab test, they get 1 point. And those get totaled up, and that will be brought to line B of our medical decision-making table. The last table is Table C, which is risk. And this is not the whole table of risk. So if you're familiar with E&M, you already know that. But if not, you can look at the guidelines in the 95 or 97 guidelines, or if your MAC has an E&M tool, they should all be using the CMS table of risk. And there's 3 categories, so you'll see that across the top. Presenting problems, diagnostic procedures ordered, and management options selected. And risk is going to be whatever is the highest in any of those 3 categories. So here I'll just point out a couple things in the moderate and high categories. It's going to be 2 or more stable chronic illnesses. So maybe that's a reason why the patient was admitted to the hospital, and that's what they're dealing with now. Acute illness with systemic symptoms. Could be some kind of prescription drug management. That would be pretty common coming out of the hospital. Illnesses that pose a threat to life, so maybe the patient had severe illness and why they were admitted to the hospital, MI, something like that. Or it could be some very intensive drug therapy where this provider is doing a lot of monitoring, drawing levels, things like that, for an example. So if you look up the full table of risk, you'll see even more examples than what we have here. So let's just do one more example of the medical decision making now that we've seen all three of the tables, and I'll just highlight these again as we go through. So let's say that we did get 4 points on that first table, number of diagnoses and management options. So we have 4 points here. And then data, we end up with 2 points, maybe 1 for lab and 1 for radiology. And then our highest risk, let's say it does end up being high. Maybe the patient was admitted for pulmonary embolus and is going through quite a bit of follow-up here. Since we have 2 in this high complexity category column right here, we can go ahead and choose the high medical decision making. And then as long as we use our other TCM guidelines and follow them with our visit within 7 days, we can go ahead and build a 99496 code. All right, that was our medical decision-making run-through, and that brings us to pop quiz number 2.
Perfect. All right, I am finding the poll right now. I'm launching it. Okay, the question is, the medical decision-making portion of the TCM service is defined by E&M service guidelines. You have a 50-50 chance. Is that true or is that false? What do you think? Looks like I got, there we go. Boy, you guys are good. I hit 100% already. Okay, I'm going to close the poll. I'm sharing the responses. Okay, Shay, we got a split here. We've got 60% who say this is true, and we've got 40% who say it's false. What can you tell us?
Okay. Yeah, so that's good. The majority of you were correct. This is true. The medical decision-making goes off of those E&M guidelines. So TCM does not have its own medical decision-making concept to follow. It's all based off of those E&M service guidelines. So that's what we just went over. Those were all based on the E&M service guidelines. All right, so now we're going to jump over to documentation requirements. So now we've gone through everything the service entails. Let's go into what needs to be documented. So at a minimum, the provider needs to document everything that's going to support this TCM service, which is going to include the discharge date, so whenever the beneficiary was discharged, the date that the post-discharge communication was done, either with the patient themselves or with the caregiver, the date the face-to-face service was furnished, and then the complexity of the medical decision-making, which needs to be supported as either moderate or high. The medication reconciliation, again, needs to be documented as well, and that's either done before or no later than the face-to-face service. And then just remember, I mentioned this before, but with that post-discharge communication or with that interactive contact, you should make at least 2 attempts and then continue to make attempts until they are successful. CMS specifically says if 2 or more separate attempts are made in a timely manner and documented in the medical record, but they are unsuccessful, and if all other TCM criteria are met, TCM services may be reported. They do emphasize, however, that they expect those attempts to communicate to continue until they are successful. If you do all of the services but you don't complete the face-to-face visit, the TCM cannot be billed. So discharge services. there's been a few questions about this, and CMS actually clarified in their FAQs this, but they say the same healthcare professional may discharge the beneficiary from the hospital, and that means they can report that either hospital or observation discharge code and bill the TCM services. However, that required face-to-face visit cannot take place on the same day that the discharge day management services are reported. So different dates of service need to be for those two services. If the patient is readmitted during the 38-day period, you can still bill the TCM services as long as you meet all the requirements. And another option would be to, start the time frame over after the second discharge. It would, just depend on what's going to benefit the patient the most. And then another thing about the discharge services is that discharge visit is not going to count as a post-discharge interactive contact. That contact, remember, has to be made after the patient leaves the hospital, and the purpose is to support the patient between when they leave the hospital and that face-to-face visit. And that interactive contact can either be by phone, email, text, or directly face-to-face, either with the patient or their caregiver. So who can furnish TCM services? Specifically, physicians and non-physician practitioners. So the non-physician practitioners could be certified nurse midwives, clinical nurse specialists, nurse practitioners, physicians, assistants. And with the non-physician practitioners, they can provide the TCM services incident to the services of a physician as long as all of the incident to services guidelines are being met. So another point is that although these services are most likely going to be used by primary care physicians, internal medicine groups, or other groups that function in that capacity, there really is no limitations by CPT or Medicare to specific specialties. So it really could be any specialty that this service is appropriate, and likewise any service that these non-physician practitioners belong to. It could be any specialty as well. So here's some more do's and don'ts for TCM. Do report reasonable and necessary E&M services other than that required face-to-face visit. So the required face-to-face visit is going to be part of the TCM service, but if the patient needs to be seen more than that, you can go ahead and bill your E&M services as appropriate. You cannot bill TCM services within a post-op global period if it's the same provider providing the global service and the TCM. So if it's a surgeon, they will likely be providing the global period follow-up and not the TCM service. Another point here to make is that Medicare is only going to pay for the first eligible claim submitted during the 30-day period that commences on the day of discharge and then continues for the next 29 days. So it's only the first eligible claim. If other specialists are seeing the patient during those 30 days, they can go ahead and continue to port their E&M services as appropriate. Here's a coding tip. This actually appears in your CPT book, so you'll see this, and this really just reiterates what we just said about the post-op period. The same provider cannot bill TCM and a global surgery, but the provider who did the surgery doesn't have to report the TCM. So just what we talked about, modifier 54 is surgical care only. And then a couple what ifs, you might be wondering this as we talked, but what if the patient's readmitted during the 30-day period? Like I mentioned before, TCM can still be reported as long as the service described by the code are furnished, including the time following the second discharge. The other option is to bill the TCM following the second day of discharge, and then you could always bill your face-to-face visit from the first period as an E&M code. So it just depends on the situation and what's going to benefit the patient the most there. And then what if the patient dies prior to the 30th day? Since it's a 30-day service period, this would mean that the service really wasn't completed. The TCM service should not be billed in these scenarios, but you can report the face-to-face visit as an E&M service. And then diagnosis codes. There's no diagnosis codes that are specific to the Transitional Care Management Service. Typically, what's going to be reported is the conditions that the patient had at the time of discharge, which are necessitating the TCM service. So what they had at the start of this service period. A little bit more on billing. Date of service has been talked about quite a bit with TCM services because when these codes first came out in 2013, CMS stated that the date of service should be the last date of TCM, so it was 30 days after discharge. And they actually changed this, and it was published in the CMS March 2016 FAQs MLN and the MLN about TCM services. So now they just say to report it as the date of service of the face-to-face visit, which is actually a lot easier, and that way you won't be holding claims for 30 days for these. The place of service, again, is going to follow the face-to-face visit. So wherever the face-to-face visit is, the place of service should correspond to it. There is both a facility and non-facility Medicare physician fee schedule payment for the service. All right, this brings us to pop quiz number 3.
Oh, perfect. I was just a little slow on that one. So let me launch this poll. Okay. If the patient dies prior to the 30th day of service for TCM, what should be billed? And I know you just covered this, Shay, because I actually did listen and heard it. So what do you guys all think? Select one of the following. Is it the TCM code 99495 or 99496? Is it an E&M service for the face-to-face visit? Or are you can't bill it at all, so you have to do nothing? What do you think? We've got responses coming in. Perfect. Boy, you guys are sharp. Okay, I'm closing. I'm sharing. Shay, we've got 80% who feel it's an E&M service for face-to-face visit, and 20% say that we can't bill it. So fill us in, Shay. What do you think?
Yeah, that's awesome. I'm glad you weren't the only one listening, Kathy. E&M service for the face-to-face visit is correct. So yeah,
okay. Let me clarify. Shay, let me clarify for our audience. I am a non-coder, so when I pick up good information, it kind of sticks with me. So that's all I meant, because I've been really listening very intently to your whole presentation.
All right. So yeah, you guys did great on that one. Like I kind of mentioned before, since there is 30 days of service in this transitional care management, if the patient dies, there's no way you can complete the 30 days, so you can't report the transitional care management service. But if you had your face-to-face visit with the patient, you could go ahead and report that as an E&M service to whichever level your documentation supports. So good job. Okay, just a few more things on billing this service, and we are getting close to the end here, but there's quite a few services that are listed as do not report with TCM. So here's some listed on this slide here, and these are going to be listed in your CPT book as well. Some of the other services that they say are excluded, and these are listed in your CPT book, they're going to be anticoagulant management, medical team conferences, education and training, telephone services, online medical evaluation series, preparation of special reports, and medication therapy management services. And the thought process here is that these services all overlap that TCM services, they're not going to be able to be paid separately. Federally qualified health centers and rural health centers. Not sure if we have anybody on the line from an SQHC or an RHC. They are not going to be paid separately by Medicare under the physician fee schedule. The face-to-face visit component of the TCM services, that could qualify as a visit. And then additionally, if you have physicians or other qualified providers who have fee-for-service practices that are separate from the rural health center or SQHC, they may bill the TCM codes subject to the other requirements for billing under that Medicare physician fee schedule. That's just an FYI. Might want to keep an eye on that in case they change in the future, because we have definitely seen that before. And then telehealth services, this was, a change in 2017, the CPT book. As far as the telehealth services, and the CPT book now actually has been marked. So you'll notice in your CPT book that transitional care management services are marked as being able to be provided by telehealth. So this is paid for under Medicare Part B services that are furnished by a physician or a practitioner, and that's via telecommunications system, and that substitutes for an in-person encounter. And then supervision. I kind of mentioned this briefly before, but TCM is listed as being okay to be billed under the Medicare physician fee schedule as incident to. The non-face-to-face services have to be provided under general supervision, so that usually means that the billing provider has to be reachable by phone, and then the face-to-face services is usually where the provider needs to be available in the room. And then the medication reconciliation, there's been a couple questions about who needs to do that. It really needs to be done by the billing provider. They state the nurse can obtain the medications, but the billing provider needs to be the one to order any changes, additions, or deletion to that medication. Teaching physician policies. If you are listening in from a teaching facility, you might be wondering if these services could be provided on the primary care exception rule. The answer is no, they're not on the primary exception list. So the teaching physician policy applies as it would just for any other E&M services, meaning the teaching physician would have to be seeing the patient. If the visit takes place with a resident or a fellow, you should put the GC modifier on the claim saying that the teaching physician has complied with all the requirements in the Medicare Claims Processing Manual regarding those teaching physician rules. Something to be aware of for your front desk staff, especially, is that the patient needs to understand that TCM services are subject to coinsurance and deductibles under Medicare. If they have a supplemental policy, they could be covered, but it is important for the patient to understand, and also understand that the primary care physician is going to be, or the primary care physician or whoever is billing this service, only one individual is going to be billing it. Another service that has been popular and is being talked about quite a bit now is chronic care management, because Medicare has recently started paying for it. And there is a couple ways these services could cross over. So chronic care management is also a monthly service, and it's for patients with chronic medical conditions that take some extra management by their physicians. What they say is TCM and CCM really shouldn't be billed in the same month, although there could be some exceptions in the rule. Since the TCM service goes by the date of discharge, it could be that all of your TCM services are completed and all of your chronic care management services are completed within that same month. Medicare does state that this should be a rare instance. Okay, we are at pop quiz number 4.
Okay, Shay, I'm going to launch it. Okay, here's the question. TCM can be reported with ESRD services, so codes 90951 to 90970. What do you think? Do you think it's true or do you think it's false? Okay, we've got, we're going to have some good discussion on this one, Shay. Looks like we've got most people have voted. I'm going to get ready and I'm going to close the poll. Okay, closing the poll, sharing the responses. Okay, on this one, Shay, we've got 25% of our audience says it's true, and we have 75% who say it's false.
Okay, great, Kathy, thank you. It is false, so you guys are correct, the majority of you. ESRD services, those codes 90951 through 90970 are listed as not being able to be reported with our transitional care management code. So good job. Okay, the next part of this, we're just going to go over a few errors to avoid. Now that everybody knows the requirements and how to bill for these services, there are a few things that come up often as mistakes. We want to make sure everyone knows to avoid right off the bat. The first step is going to be having a process to identify patients that have been admitted to the hospital. If you don't know which patients are going to be discharged from the hospital, you're going to have a hard time billing for these services because of those time frames that are required by TCM services. So not only will the office need to know who's being discharged from the hospital, but we'll also need to receive the discharge information. So perhaps there's some kind of electronic health record process that could be put into place, or some kind of communication that's going on between the inpatient and outpatient setting in your facilities. The next one is understanding the timing. So I did harp on this quite a bit, but that's because it's confusing. So it does take a while to kind of get this nailed in your head, but the discharge communication has to be within 2 business days. The face-to-face visit has to be within 7 to 14 calendar days, and the 7 to 14 calendar days are part of the code requirements. It's going to differentiate whether you're going to be able to bill for the 99495 or 99496. That and the medical decision making, which is the next error to avoid. Remember, the medical decision making has to be either moderate or high complexity. So that's going to follow those E&M guidelines. And although many patients will probably meet these guidelines, there are going to be some that don't. So one example I think of, and this could be because I had a baby recently, but if a healthy woman goes into the hospital, gets discharged after a normal delivery with no complications, they're probably not going to meet that moderate or high complexity decision making that's required. So that's another thing to think of. And then just reporting the TCM codes. So with the revision they did on the data service requirements in 2016, that did help with this. And it seems like an easy process to follow, but it would be easy to submit an E&M code instead of that TCM code on the data service as the face-to-face visit. So just be aware of, if your intentions are to bill TCM, you would bill the TCM on the data service as a face-to-face visit instead of your E&M code. And then missing documentation, which could be applied to, I think, any service we bill for, but especially in TCM, remember the documentation has to reflect all the requirements of the TCM service. So we need the date of discharge, the patient was discharged from the hospital, the date the interactive contact took place, the date of the face-to-face visit, the medication reconciliation, and then support of the moderate to high medical decision making. So if any of those elements are missing, your TCM service is really not going to be supported. Bottom line is there really is some incentive for billing this service if this is something you are providing or your office is providing. And you can see that reflected in the Medicare physician fee schedule. So what we have here is just the TCM codes on top compared to our higher level established E&M codes. So you can see if you're already doing hospital follow-ups with your patients, it might be worth it to look at billing TCM codes if you're providing those additional services and can meet all of the TCM service guidelines. On the fee schedule, it's reflected as a higher priced service. And finally, we have an example. Let's just walk through this. We have the date of discharge as 4/6. That's a Thursday. The interactive contact took place on Monday by phone. The patient speaks with the RN. They review discharge information and they schedule appointment. The appointment takes place on 4/12, and the provider documents high complexity. Looks like the patient has a number of problems, recovering from an acute MI, has severe COPD, on a bunch of complicated drug therapy, is attending outpatient rehab. They did the medication reconciliations during the visit, and then also did a number of non-face-to-face services regarding the rehab, oxygen use, education, and this was all provided throughout a 30-day period. So we really have all the elements of TCM service. We have the 99496 code would be reflected. The date of service would be 4/12. We have all the requirements met: the interactive contact, the face-to-face visit, the medical decision-making complexity, and that medication reconciliation. The place of service is going to be corresponding to wherever this outpatient visit took place, and your diagnosis codes are going to be reflective of that MI and the severe COPD. So that's our case study, and then we're going to wrap this up with pop quiz number 5.
Okay, here's our last poll. I'm launching it. So post-discharge, how many days must the interactive contact with the patient or caregiver take place within? And I know Shay, she said she harped on some of this stuff. Is it 2 calendar days? Is it 7 to 14 calendar days? Or is it 2 business days? So what do you think? We're talking about post-discharge. How many days? Okay, boy, you guys are quick. Okay, I'm closing. I'm sharing the responses. Oh boy, we've got answers all over the place, Shay. We've got 20% who feel it's 2 calendar days. We've got 20% who feel it's 7 to 14 calendar days. And we've got 60%, so the majority say it's 2 business days. So help us out, Shay.
All right, it is 2 business days. So like I said, the timing of all of this is confusing, and it's even more confusing. They jump between business days and calendar days, but just make sure that's something you understand if you're billing for the TCM services. So 2 business days is the TCM requirement for the interactive communication post-discharge with the patient. The calendar days is going to be reflected in the face-to-face visit. It has to be either within 7 or 14 calendar days. So that is all of, oh, sorry.
No, I was just going to add my 2 cents, and I just thought going to be any more confusing between the calendar and the business days. So
right.
That just kind of flipped out, Shay.
I know. Okay, I did want to point out our resources here. So CMS has a number of resources that they published on transitional care management service. So there's an MLN fact sheet, and there's FAQs that are published. You can find those on the CMS website. I put a couple of resources for practices out here. from AASP and ACP Online. So those are just some practice resources, some checklists, some templates that could be used, and those are all in regards to implementing transitional care management billing. So those can all be found there, and I thank you guys so much for listening today. I really appreciate your time, and I hope you learned everything you need to know about transitional care management.
Perfect. Shay, we did have a couple questions come in, so I think we've got time for just to answer just a few of those. So the first question is, and I think you might have actually covered it when you talked about the resources, but somebody asked early on, where is the best place for me to get the decision tables that you were using and talking about in the presentation?
Oh, yeah, that's a great question. So those are reflective of Novitas, which is Colorado's MAC, or Medicare Administrative Contractor. So I would suggest going to your MAC, which is going to be different depending on which state you live in, and looking at their E&M tool and really understanding how they're calculating their E&M services. Another really good place for the tables is going to be just right out of your 95 or 97 E&M guidelines. So medical decision making is going to be reflected by the E&M guidelines. So you could do CMS guidelines or your MAC as well.
Okay. Thanks, Shay. And we've got one more question from in. So can transitional care management services be reported if the patient is on hospice? So for instance, they said the example was if the patient was discharged home on home hospice services.
Okay, that's a really great question. This was actually answered in the CPT assistant, and I believe it was August 2013. The question about hospice services, so hospice could be taking place in a number of different facilities, or it could be home hospice. Specifically in the CPT assistant, they address home hospice, and they say, yes, that would be appropriate, as the guidelines do not prohibit this. They do prohibit, and I've seen a number of MACs address that if the patient's discharged to a skilled nursing facility, that would not be allowed to be reported as TCM services. So if the hospice is in a skilled nursing facility, it would lead me to believe that that TCM services would not be appropriate. Like in your question for home hospice services, they do say yes, that would be appropriate.
Okay. Oh, perfect. Thanks, Shay. Well, and I think that's, we're out of time. You've answered our questions. I want to thank everybody for their time. As you can see, kind of who we are has been on the slide. And if you liked our webinar this month, just know for next month, we've got on June 6th, we've got chronic care management for you Profi coders and Profi people out there, as well as on June 8th, we have wounded by wound care coding for those facility coders. So thank you again, Shay, and we want to thank everybody for taking time out of your busy day to learn about transitional care management today. So thank you very much, and have a great day. Bye-bye.